everyone. Thank you for taking time out of your evening to participate in this work group. My name is Behnam Tehrani. I'm an interventional cardiologist at Inova Health System. It's a pleasure to have you all. We all want to collaborate and work together around a common theme, which is developing protocols and mutually agreed upon practice patterns for a disease process for which there is a lot of heterogeneity, regionally, nationwide, and worldwide, to help improve outcomes. We really appreciate you guys taking the time to participate in this survey. As we can see here, we have a number of physicians and other professionals from our institution at George Washington University, Dr. Mazhari's group, Carillion Institute, Dr. Joseph, University of Maryland, UVA, Valley Health, and also Riverside. As this survey was submitted in terms of understanding where people are currently in terms of managing this disease process, able to go to the next slide. There it is. In terms of understanding where people are currently at in terms of managing this disease process, do they have protocols in place? As you can see here, it's a bit of a mixed bag. Two institutions reported yes. One institution said no, but they're definitely interested in developing it. And then there were a few others that were in the process of putting these protocols together. Next slide.
Actually, that is all we have.
That's the last slide. So, this is our first meeting. We'll have these regularly. But we wanted to open this up to kind of get some feedback from people on this call to really understand better where you are at your institution, where what are some potential roadblocks, if you will, that you may be encountering in developing protocols and teams, and what do you see as opportunities to move forward? Because I think there's certainly opportunities for collaboration, certainly opportunities to better understand how this disease process is. And there's a lot of questions out there in terms of clinical knowledge gaps as it pertains to diagnosis, management, systems of care, but also other areas further downstream in terms of futility, because there's clearly a broad spectrum as it pertains to this disease process. And really, we're all learning together as we move forward. So I will open this part of the conversation up to kind of get some feedback from everybody on the line. I can just start off by saying at our institution, and I see Dr. Batchelor's on the line and Marian's also on the line, we've had a protocol now for about 3.5 years. It's a protocol that's been an evolution. It's a protocol that we really opened it up to what we thought were the main stakeholders, which at our institution, it's interventional cardiology, cardiac surgery, advanced heart failure, in conjunction with our cardiac intensivists. And the emergency room is also involved in that protocol, especially upfront, upstream. These patients come to the emergency room either within directly at Fairfax Medical Campus or to one of our referring hospitals. And for us, in fact, almost 55 to 60% of our patients come to our main campus here, our hub, if you will, from these other centers. And so, developing, regionalized collaborations and systems of care for us was very important as we, collaborated with institutions that maybe a level 2, which is they have a cath lab, balloon pump capability, plus or minus Impella, level 1 centers which don't have cath lab capability. And it was important to make sure that people understand, what the process is, what are some of the clinical criteria to diagnose this disease state, what are some hemodynamic criteria, and what are the endpoints, and what are we looking for. So that's where we've been in our protocol. We have now our own IRB registry, over 600 patients. COVID-19 certainly, was an interesting aspect of all of this, because we saw patients with a whole different level of acuity that presented, obviously, like many centers around the country. We saw a decline in our STEMI volumes, but the shock patients that came in, we saw a much higher level of acuity, and late presentation infarcts, mechanical complications, and also somewhat of a higher number of the acute decompensated heart failure patients. And whether that's part and parcel with, this disease process, is certainly interesting, but, we certainly want to open this up to people on this call. We look forward to working together, collaborating, and coming to a mutual understanding in terms of how to approach this lethal syndrome.
Behnam, I wonder if we can maybe just have a little bit of clarity around goals and objectives of this for this work group, so that we're all kind of on the same page. Obviously, collaboration is going to be the theme, but is the overriding sort of goal of this work group is to come up, I presume, with perhaps some ideas and a structure that we might be able to present to VCSQI as to how we might be able to study cardiogenic shock further, and through a Virginia VCSQI sort of collaboration of several groups. I mean, is that the task that we're charged with for this work group? And can we get a little bit of clarity around that? And then it'll help us understand how to frame the discussion, I think, just understanding where we're supposed to end up with these discussions.
Great question. So I think this is, really, we have the opportunity and we have a little bit of leeway in terms of how we want to, take this and how we want to move forward. I think certainly, coming up with some clinical questions, areas where there can be some areas of collaboration of study, I think will be a very important aspect of it. This was, added to the VCSQI agenda, just as, based on a couple of meetings that we had back in June. So this really is open to all of us here to come up with some ideas, some clinical questions that we may be interested in, and see if there's areas for mutual collaboration in terms of understanding this disease process within certain areas of focus.
Do you think that the manner in which we're each collecting data is going to be granular enough, detailed enough, and robust to really ask any kind of major clinical question? And are we all collecting it in the same fashion for all the data elements that we think we would need to do a proper shock study?
That's a good question. So, I mean, internally for us, we collect a lot of granular information longitudinally, so at the beginning and also at serial time points thereafter. I think that's one of the things that we wanted to talk about with this work group here. It's for people that have protocols or developing protocols, what do they envision? I think, developing these registries is going to be very important. So we know what exactly we're looking at, what variables are going to be feasible, because it's going to require some manpower and some work to undertake that. At our institution, it required a lot of support from physician and administrative leaders, and obviously every institution has their own internal structure and culture, if you will, and so. I think we can certainly come to a consensus of what we think are important variables to collect, and what can be looked at prospectively and also retrospectively in terms of answering some important clinical questions.
Yeah, this is Sula Mazimba from UVA. I like the idea of really harmonizing data collection amongst the institutions and working around that data platform that we create so that we can sort of answer specific questions on cardiogenic shock. I know the surgical colleagues have really done a remarkable job through the VCSQI to really be very productive in terms of producing a lot of scholarly work on surgical outcomes and quality initiatives across the Virginia. I think that we can use their model in terms of getting a unified platform for data collection. I think that's certainly something that we can work around.
Dr. Mazhari, how about at GW? What do you all have in place?
So we're in the process of developing a protocol. We're currently part of the Cath Pci Registry. And I was going to ask Behnam, are you referring to one of the national registries, or we're trying to create our own registry and collecting our own data?
That's a good question. So NCSI is a very specialized subset of patients. As you know, it's the acute MI patients that get unloaded first and they get revascularized. I mean, we're also part of that, but our own internal registry is an all-comer registry. So it's not necessarily people that are eligible for a clinical trial or a clinical question. I think that's something that we found has been very interesting because we've been able to answer some questions around these patients, because depending on where you look at, the acute decompensated heart failure subset can be 30 to 60% of the patient population, whereas NCSI is a very particular subset. And they have a lot of exclusion criteria, cardiac arrest downtime, late presentation, mechanical complications. So I think that's a very nice subset to look at. But one of the things that we've done, and certainly this is why we wanted to open it up to the group, was perhaps looking at an all-comers, because I think all-comer data is what's really interesting in terms of nationwide, both in terms of practices that are utilized for taking care of these patients, but also understanding a little bit more about the overall broad spectrum rather than one particular subset of patients.
And this is again different from the Tufts registry.
Tufts registry, that's the cardiogenic shock working group. That's also a broad registry, and they look at a lot of these patients as well. They don't have as many exclusion criteria. Again, this is up for this group to come to an understanding. We look at all of these patients, whether they get an intervention, whether they get a device, or whatever their phenotype may be. When we have people that we look at that have mechanical complications and sepsis-induced cardiogenic shock, obstructive shock from PE, valvular heart disease and shock. We look at the whole spectrum.
And what does it take to be part of this registry? It's retrospective, so we can go back and look at some of the shock patients and enroll them?
So good question. So one option would be to come to an understanding of what we want to look at, because we may come to a consensus about what variables we want to see. A lot of it depends on hemodynamics. Not all institutions have a clear protocol for who should get a PA catheter. So in one way, if you go backwards, some of the data may not be available, but another way would be to move prospectively forward to come to a conclusion or come to a consensus of what we want to look at and move forward as we start to enroll patients in a prospective manner.
One thing
Sorry.
one thing I would say, so Sula mentioned the success we've had with the surgery side, and I think that's because of the fact that we use a already established data collection form, which is the STS registry and the STS data. And so I think it's going to be really difficult if we don't have kind of a standardized, pre-existing registry that we can all use, to have kind of to develop a new thing from the ground up just for the VCSQI is going to be, I think a lot of work for all the centers, and I think, difficult. It'd be nice if we could find an existing registry to kind of collect that data for, and then use the, the compiled data from all of our centers.
Yeah, and that's an excellent point, Nicholas. I would tend to agree, and I think what we're going to need to understand is what do we have to work with. And so Sherry, maybe you or others can chime in on this in terms of how much support do we have to do this? What are the expectations in terms of developing a new database versus working with what each of us have? One thing to do in these scenarios where it's a little bit nebulous in terms of how we're going to get from point A to point B is to just come up with a good question that's easy, that's practical and pragmatic, that wouldn't take a lot of data collection to answer, but we can leverage the multiple centers that have a fair amount of volume to get it answered quickly. For example, weaning protocols off MCS. What are the predictors of successful weaning? And it's a very simple question. Weaning strategies that work versus don't work. Those sorts of things. So I guess my question would circle back to, I don't know if Sherry is the right person to answer this, but to stem off of, springboard off of Nicholas's point, what do we have to work with here, and how much we can't ask, there's only a certain amount we can ask sites to do. What is VCSQI able to offer in terms of support, et cetera, and what databases are we expected to employ in this regard?
Okay, well, I will start by answering that question. You have the full resources of VCSQI behind you. As it relates to the data that is available, I will hand that over to our data guru, Eddie Fonner, who's also the executive director of VCSQI.
Thanks, Sherry, and Dr. Tiemann, you make a really good point on data collection. I feel like it's something that, for me, has driven our success in STS and is starting to light the fire with our new Cath Pci data set. At the same time, if there's not an existing registry out there that people are not participating in, getting folks up to speed, dedication of FTEs to collect data, it's going to be a long process. So I'm not saying we should completely count it out, but at the same time, I feel like that would be more of a long-term goal for us as a group. And at the same time, like Dr. Batchelor said, if there are some kind of quick wins, some protocols that we can study from other institutions and implement and learn from, that might be the best usage of this work group's time as far as immediate collaboration with keeping in mind those long-term goals to data collection.
Eddie, is the purpose of the working group to put forth big ideas that the VCSQI would take into account and try to promote and perhaps spread more broadly? Or is it more to come up with some kind of pilot small project that's lower hanging fruit where we can gain some traction? Or is it both or neither?
That's a great question. I would say it's probably both. I mean, we have to realize, I guess, time limitations from our members and be sensitive to, the 100 other balls that you guys are being asked to juggle. So we don't want to necessarily bite off, more than we can chew. At the same time, I think we want to think big and we want to, have as big of an impact as we can. So it might have to start with that, sort of smaller pilot project and then work toward a bigger initiative. That's kind of how I would frame it.
It's kind of important because if we're just putting some thought to this, you kind of have to think what's doable, what's not, how much time you have, and how much effort it takes. So it sounds like we're sort of gravitating around some kind of simple project that wouldn't require much more than a couple of pages of a case report form that can be easily be filled out, kind of thing, or 2 to 3 pages, but not like a 20-page case report form. Other comments from other folks on the line in terms of what can we really realistically do that we might be able to gather some traction for? Behnam in the past has had some really neat ideas around just understanding the patients who have pre-shock, have, through systemic vascular resistance or maintaining decent blood pressures, but are, clearly low cardiac index and have a really poor outcome. There might be some opportunities to define the prognosis of those patients by just all of us agreeing to collect information on that particular phenotype. That's one thing that I can envision, that you can just muster a lot of volume, but not ask a ton of questions around and get some useful information.
Yeah, and I think with the new SKY staging system too, although it's a dynamic scoring system, at least they classify exactly what those patients are. So it'll be the stage B, and they put some granularity around those, and we can look at them and follow those patients prospectively. Those patients in particular can have a high mortality, especially on the acute MI subset.
Yeah. The other practical thing, and I'll shut up after this because I'm talking too much, is regulatory and IRB stuff. So the way that we get around this at Inova, we actually have an IRB submission that allows us to collect our information and then ask questions around it. But again, if we decide to do something together, then we got to decide, is it going to be just something that is prospectively collected that might, and then a data dump into a common database of some sort that's the case that has a slightly different path, and perhaps some of the stuff that we do at Inova, which is largely retrospective. We're collecting it in real time, but we go back and retrospectively analyze it from our own particular data.
Yeah, I think we have an opportunity here where a number of centers have not yet come up with their protocols, and but they working towards that. So I think that this is the best time to sort of start thinking about a prospective sort of aspect to this working group, so that people can already start. Not everyone can come on the same level at the beginning, but at least we can coalesce around some framework that we can, as people join and they form their programs, they can sort of work around prospective data collection, while at the same time we may be looking at some retrospective studies and answering specific research questions. But I think that that's how I think that the success of this working group would probably be, especially if we look at some of the work that the surgical folks have done in terms of really driving some of the quality initiatives and scholarly work that they've done, which has been an amazing sort of feat.
Yeah, and I don't know the answer. I mean, there very well may be registries like that one of you all mentioned earlier that we could just all participate in, and that way that data is being collected, and then we can just combine our VCSQI, iterations of that data. I just don't know. I don't know what's out there enough to be able to say whether what is out there is sufficient for what we're trying to accomplish. But I agree. I mean, the opportunity to use this data and answer a lot of clinical questions is there's definitely a great opportunity there. Yeah,
I agree. And there are some data sets that we could sort of use off the back. For instance, the Cath Lab Registry, the SEC Cath Lab for patients that have that go through the Cath Lab and get some mechanical support and so forth. I think those are captured. And then we could sort of obviously look at other registries that we're going to be part of. I mean, we're also going to be a part of the NCSQI registry, and the National Shock Registry, the SES registry. So I think that that will also be a rich database for gathering data from a retrospective standpoint.
So, these conversations are interesting because each of us are in slightly different phases of developing shock programs. Each of us has a sort of heterogeneous commitment to other existing databases or national efforts. Some of us have our own database. And I think the real challenge in this working group is to as Sula said, is to coalesce around one common theme. So we may not get that answer from this particular call. It might take some emails and some thoughtful considerations. But I would kind of envision finding out where there are gaps in knowledge, and thinking of a pragmatic study that would not require a lot of heavy lifting to get a very simple question addressed. Remains in the shock, in the era of shock therapy and management. And that might require a little bit more thought because again, we're all coming to the table with slightly different perspectives, degrees of development of shock programs, and actually data collection opportunities. I wonder if maybe VCSQI or perhaps Marion can chime in on how much data are we able to collect? We're getting the Cath Pci, everyone's gathering that. And I don't know, Marion, I think you're muted, but if you can chime in, how much information on the shock patients is collected through the Cath Pci Registry? How much information on MCS, et cetera, and hemodynamics? I don't think there's a ton, but maybe you can fill us in on that. I saw Marion unmute her phone. How about for the VCSQI data? How much, maybe we should circulate what's collected and to what level, et cetera. I just don't know off the top of my head all these details.
It's a good question. As far as adult cardiac surgery, I mean, we have a pretty much a binary, yes, no, did a patient have cardiogenic shock or not? I don't really know what other sort of clinical details, other than the standard labs that are collected that would be useful for a project like this. It's pretty limited. I mean, we do have all the surgical cases, and we do have a good proportion of the PCI cases, but it's sort of like a broad stroke, but it's not very deep, unfortunately.
Well, one thing we've talked about in the past, which is an opportunity potentially, is using ECMO registry data for the patients that would progress from cardiogenic shock to requiring ECMO. Obviously, we miss a lot of the patients that we're trying to capture, but I don't know. I'm kind of assuming that the major ECMO centers in Virginia submit their data to the ELSO registry, but that data for patients that require ECMO could certainly be compiled and accessible.
It looks like Marion has weighed in via the chat feature. She says, Cath Pci would collect if patient had shock, pre, post, during procedure. We don't collect pressure, and we collect some labs, but not all that you might want. We do have whether a patient had left vent support.
Yeah.
Behnam, poor Behnam was the guy who basically built our database and collected all the data for the first long time, so he probably has a pretty good understanding of this. Do you know how large our actually Inova shock registry database is in terms of numbers of, let's say if you had to say it was 5 pages of case report form or 3, just ballpark, how many?
Yeah, it's about 3 pages. So it asks simple questions, demographics, risk factors, baseline lactic acid, was it an acute MI, was it decompensated heart failure, and it'll ask some basic questions around hemodynamic parameters at 0, 12, and 24 hours. I think it's feasible. I think if a lot of it comes to a mutually upon agreement by people in terms of using the PA catheter. I know in certain institutions it may be used much more frequently and less so at others. So a lot of ours is dependent on that, and that's where we get a lot of our information. But it's pretty feasible. It's not too time exhaustive, and I think if we all agree upon those variables, I think it can be looked at. And there's certainly important questions that we've talked internally amongst ourselves in our institution that we've thought about, and there are others that I'm sure we could collaborate with the physicians and others on this line.
So Behnam, I am still trying to understand if we're going to all adopt the same protocol based on some of the baseline hemodynamic information, or are we recognizing that among the 7 institutions here on the line, people probably have their own preferences and gravitate towards different kinds of percutaneous mechanical support devices, and we're just maybe collect the data based on each institution's protocol and answer the big question of, which one of these, because there has been this exponential production of all types of mechanical support devices. And I'm not sure if we have data to tell us which one is better or which one is really indicated for what phenotype of shock. Are we trying to adopt the same protocol, or are we going to just use our own institutional protocol and then look at the data and look at outcome?
Great question, and that's one that I was thinking about before we got on this line, because as you know, nothing has been really prospectively validated in shock. Not a PA catheter, not a device. Nothing has been shown in a randomized controlled trial to be the superior mode of doing this. Some institutions are very heavy towards ECMO. They'll go straight to ECMO on these patients with very little venting. Some institutions are heavy towards Impella. Some institutions just believe in a balloon pump and then will bypass an Impella to ECMO. And others will do an ECMO, and they have various strategies around venting them. I know we have a lot of that internally. I think a lot of it comes down to, you know, how these patients are taken care of regionally and I'm sorry, institutionally. So I think it may be a bit difficult in terms of coming to a mutually agreed upon universal protocol. But I think if there's some basic understandings or basic premises that we think that these patients should have. So a PA catheter when they come in, collect, you know, the lactic acid, the cardiac power, and other variables of right side function at 0, 12, and 24. And I think, you know, again, none of these devices have been prospectively validated. And I think, you know, we can look at this information and we can, I think if there's some degree of differences, if you will, in terms of how these patients are taken care of, there's a lot that can be learned about these patients.
But I think, you know, this is Farzad. I think having a randomized controlled trial for devices for shock is a very difficult trial to run because it's always the physician's intent to treat. And, you know, it's going to be a pragmatic design no matter how you do it. And then I think for the regionalization of the data collection, I think the only thing this region can offer is collecting the data, creating a registry, and then possibly doing a propensity match so that, you know, we're comparing apples to apples and oranges to oranges, because, you know, some institutions may be more aggressive in triggering device support and some institutions may not be as aggressive. So I think RCTs are going to be very difficult to run on. First of all, the sample is not going to be huge, and to show a statistical significance of any mode, because, you know, if you look at the ELSO data, we're not, no institution is doing millions of ECMO or Impellas or PVADs. So that's a very difficult trial to run.
Yeah, I'm not sure Ben was suggesting that we do a randomized trial, but I think he's just saying that any incremental data in this realm would be helpful, even observational data with collected with adequate numbers and decent quality. So one thing that maybe we can get out of the call is just maybe to have some kind of agreement to try to just collect data that's similar and make it not too onerous to the sites. But maybe if, you know, Behnam, if you wanted to share what we collect and other people can share what they collect, whatever have you, if we can just get to the point where we're collecting similar data, then we can pool a fair amount of information together pretty quickly. Within literally 6 months to a year, we have hundreds upon hundreds of patients theoretically if we were really truly doing this in a collaborative fashion. So maybe that's the first action item, is to see if we can agree on collecting the same data at the same time points. And to Farzad's point, obviously a prospective randomized trial is kind of out of the scope of this, you know, this working group. But I think observational data that's propensity matched or risk adjusted and multivariable analysis is within the framework of what we could manage.
Certainly. At other institutions, what do you guys typically collect? And I know there's people that are in different phases of this process, but at sites where you take care of these patients, you know, what is the practice pattern around using a PA catheter? What variables do you look at? And I'll be happy to share what we have with this group. I'm curious to see what others think.
Yeah, so we are just in the middle of getting our protocol at UVA for our shock registry, and then, but of course we also have the NCSI registry that we are also going to be implementing. It should be starting this month. So I would say that you know, we would love to share. We would love to get your data collection tool, and that as we move forward, we could certainly incorporate some of the data collection protocols that you have, and we can take it from there. Sorry guys, I have to run, but I think that I like the focus, the direction of going towards harmonizing the data collection process, and then we can subsequently answer questions as we go along.
So I wonder if the the action item from today's meeting is to circulate what each of us has, or at least you can start off with the Inova, not that we're trying to promote it or anything, it's just trying to come up with something that's common, and everybody chime in. And if we can come up with something that's like a 3-pager or 2-pager that we just all agree that we collect, then I think we could be far better off than where we are now, and we get to this point of harmonizing the collection of data. And then we can really start to put forth some questions and that we could probably answer much more readily rather than just kind of Inova or UVA or any other center just trying to do it on its own. Does that make sense to everyone? Or?
Yeah, and then also just keeping track, like Sula said, of where people are reporting data to also, because a lot of that work might already be being done as opposed to developing a new thing.
Yeah, it's always hard, even if you're reporting it somewhere else, it's always hard to extract it, It's challenging. Yeah, sometimes you have to. It's easier just to make a little small case report form and just get it as you go along, rather than it's being dumped somewhere else. And you got to figure out how to extract it, the right data, and it gets tricky. I'm not an IT person, but I know it's.
Well, that's where Eddie comes in. He can take care of that.
Hey, this is Charlie Evans from St. Joe's, Maryland. One thing our group was talking about, and we're at the very early stages of this, is if we could include in the things to circulate everybody's definition of shock, because I think we all kind of have an idea of what it is when we see a patient, but at least at our institution, we don't have a set standard definition in terms of, systolic blood pressure or needing inotropic support or end organ function. I think it's something that we recognize when we see a patient that has it, but we don't have a standard definition for it. I was wondering if anyone else does, if they could share that.
Charlie raises to me a really good point. When we look at the Sky Shock score, I got to tell you, it's pretty darn subjective on the C's and D's. We've seen some reports of Sky Shock D's having really low lactates, and it just doesn't make sense. It's clear that some of that is just in the eye of the beholder, and if you're putting a device in, by definition, you're probably automatically a C or a D, and you're more likely to upgrade the Sky Shock severity just naturally when you're putting a device in. So, I think that's a great point. Whatever we do, we're going to have to collect what the status of the patient is and agree on what system we're going to use to score that, and maybe even look at more than one system. So, Eddie, do we have what sort of help can we give sites if folks are already collecting this? I'm trying to understand, how can we make this easy for everybody on the call if we decided to do something cohesively? Let's say we got it down to 2 or 3 pages of data elements that we wanted to collect that could be relatively straightforward. But some of these folks it's already being put into an electronic database, or maybe it's going to, some of it's from Cath Pci. Any thoughts on how we can systematically get the same information in a single database, or should we just extract it from, I'm not sure functionally how to do this as a group. If we agreed on collecting certain things, functionally, what does that mean?
It's a really good question, Dr. Batchelor. I think we would have to potentially look, I guess, first of all, from a kind of a legal perspective, and just in terms of making sure that we're covered to aggregate this kind of information from folks. Like right now, we have separate data agreements for both Cath Pci and STS. I don't know if that would cover anything outside of that or not, though. So I want to make sure that we're safe with the data, first of all. Assuming we can get that part figured out, we would have to talk to our database vendor, Armis. And what they've done in the past is they've set up a portal for folks to upload their data. And at that point, it's ingested and aggregated, and then we would have access to it from a de-identified point of view, and be able to report on it and generate pieces to share with everyone. So it's kind of a multi-step process, I guess.
Marion had indicated that we can add data elements, custom fields, to the Cath Pci registry. It would only be in the PCI patients who have shock, but that's another means through which we could theoretically come up with a common data collection tool. just use the Cath Pci Registry, create custom fields and do that. That's one other way, and extracting that might be easier than coming up
Dr.
with
Batchelor.
Yes.
It's Marion. Can you hear me? I
Yeah,
finally got
yeah.
myself unmuted. For other places, we only collect PCIs currently. Other hospitals very likely are collecting diagnostic caths. So potentially it would be that group of patients too, who come into the lab, have a diagnostic cath and are in cardiogenic shock, just don't have a PCI. Those hospitals could, you know, do those custom fields as well.
How easy it is to extract data from the Cath Pci Registry from a single center? I know we get all of our reports on bleeding and various things. Can we do our own queries and ask specific questions?
Yes, we can. Because we enter our data, we don't do direct to the registry. We enter our data into Apollo, which is a vendor like Armis, but it's not Armis. We put it into Apollo, and then we can, at any time, query that data, and we do.
What about the other centers that are on the call? Does anyone know? I don't know if you all know the answer to that question. Do you have a secondary sort of interim database that you populate for the Cath Pci Registry, or how's that entered? Anybody know from their sites?
Actually, I can venture an answer, and Eddie, maybe you can confirm this with me. I think that all but 2 or 3 in the state of Virginia are using Armis to put in their data. I don't know of anybody who's doing directly to the registry. You can directly to the registry. Most places don't want to do that because then they can't get their data back as easily. So I believe that, Eddie, could you chime in?
Yeah, that's correct, Marion. And with Armis too, folks would have the option of being able to add custom elements, and they could pull that data themselves too.
And I don't know if you've seen any, we're just starting to do the Cath Pci reports at VCSQI. Those reports, Armis has pulled from our database. It gets dumped into Armis, and then they make a report for VCSQI that compares us across the state.
So Behnam, do you think if we cross-reference the Cath Pci Registry with the Inova shock registry information, and some stuff's going to overlap, some won't, but there might be a few custom fields we'd have to create. Between you and Marion, do you think that that's doable, and that would be the shortest path to coming up with this common database?
And we're just looking at the AMI patients then.
Yeah. The downside of that is we wouldn't be looking at the acutely decompensated heart failure shocks. It would be just really mostly the AMI patients.
Yeah, I think we can do that. I mean, we have enough variables that we look at internally as well. We can see how much of that can be cross-pollinated to look at. I don't believe the Cath Pci Registry looks at hemodynamics, man. I think, like you said, blood pressure, if they've got a device, and if they're on pressors. Is that right?
That's correct. We don't do any of the pressures, but I mean, it's in the report. We could look at it. If you do a custom field, we could put it in there. But really, we would have to compare the two, or you can, I can send you the.
Yeah, and that definition that we just mentioned, the Cath Pci uses, that's what was used in the IBP Shock 2 study and a lot of the other ones that have been done. I mean, only one study that I know of is look at hemodynamics, and that was a shock trial. Everybody else has used just blood pressure. Some have used LD-EDP, but the rest have just used blood pressure and device.
And I think what you have in mind is more of a detailed hemodynamics with the CPO and PAPI, and I doubt we can extract that from the Cath Pci Registry. What you have in mind needs to be created manually, because we tried to look at our registry, and it's just there's positive information there. It makes it very time consuming, and you still don't get the data you would actually need to phenotype shock. Because I think you're trying to update the definition of shock and sort of get down to the bottom of what phenotype. And for that, I think we need to start creating registries with that vision in mind.
Yeah, I mean, I think that's one of the things that we have in mind is to be able to better understand the phenotypes of these AMI ones that come in, whether they're purely LV, RV, BIV, pre-shock. But it's going to be time consuming, and we have to come to a consensus in terms of what we think is feasible and what we agree upon.
Well, this is going to be one of those meetings where we're going to have more questions than answers, obviously. But I think we're going to have to just come, somehow from all of this, see if we can come up with some low-hanging fruit, something that we can do that would spurn more discussion, thought, hopefully lead to some simple data collection. Think about it, IRB processes and what this would mean for, do we need to submit this or can we just collect it? What does that mean? It's in the Cath Pci Registry. One of the nice things is you can extract that information. You don't need an IRB submission, necessarily a research submission for it, I don't believe. Marion, we can probably just do that, can't we?
I would have to check to be certain. As it stands right now, no, anything in the Cath Pci Registry does not go before our IRB.
Right. So maybe Behnam, you want to, someone can summarize some of this stuff and we can send out an email to the constituent members of the group and sort of say, have everybody chime in on what they have, what they can collect. Maybe we can share, if you're comfortable sharing some of the Inova shock data.
In case report form, sure.
Report form. And if everybody feels that that's doable, maybe we can just start collecting similar data. If we just get to the point of collecting similar data, we can ask a lot of questions, and then we can submit them to an IRB and get them answered. But the hard part is going to be getting us the same data place, and in terms of data collection, where it's housed.
Great. Yeah, we'll get that to you guys in the next 24 hours. We'll get you the variables.
Any other comments or suggestions, or just trying to get us to the next step here? Well, great. Behnam, anything else from your end or Sherry?
Yeah, actually, my next question is, when would you like to reconvene to follow up after the collected information?
I thought we have a meeting in next month, don't we? I saw it on the schedule. I forget what day it was.
Actually, that might be our quarterly meeting.
Oh, that's right. That's the quarterly meeting. So I can get this case report form out to everybody in the next 24 hours. We can maybe 2 weeks from now. What do people think about that?
Yeah, anytime before the quarterly meeting, it'd be nice to be able to have something intelligent to say at the quarterly meeting.
So maybe 2 weeks from today.
Okay, I'll arrange it.
Yeah.
Thanks.
All right.
Good discussion.
Yeah. So we'll get this circulated out to everybody and just take a look at it, and then please provide some feedback, and we'll hopefully continue to move forward.
Great. Thanks.
Thank you.
Awesome. Thanks, everyone.
Thank you all.
Thank you.